much. I'm honored to be here in this important meeting. We will talk about the risk factors of sudden cardiac death in Egyptian patients younger than 40 years of age. We all know that sudden cardiac death is an important problem with multiple etiologies and risk factors, and we all know that sudden cardiac death is defined as cardiovascular cause which occurs within 1 hour of the onset symptoms when witnessed, or if it is not witnessed, an unexpected death from a cardiovascular cause where the individual was observed to be alive within the previous 24 hours. Sudden cardiac death is a major cause of mortality, accounting for about 10 to 20% of deaths. And there are many potential cardiac causes of sudden cardiac death, like cardiomyopathies, like primary electrical disease, conduction system disorders, inherited heart diseases, and abnormal heart rhythms. Actually, the incidence of sudden cardiac death, if it is considered in general population, 1 in every 1,000 per year, the presence of a previous coronary event increases this incidence up to 5%. And the presence of an impaired ejection fraction of less than 35% increases this incidence to 15%, up to 20% in any survivor for any previous cardiac arrest. And the major problem of sudden cardiac death, that it can be the first presentation of an underlying cardiac condition. And also many cases are considered familiar or maybe familiar in origin. So it is very important to know the families who have a history of sudden cardiac death and try to identify these risk factors to reduce the burden of sudden cardiac death. So in a study which was a part of a master thesis of one of our residents at Ain Shams University, Dr. Hind Ali Abdel Tawab, and under supervision of Professor Mirvat Abul Maati, Professor Ahmed Damanhouri, and myself, we had a study, and we did a study to see what are the causes of death in a cohort of Egyptian population who died suddenly or were resuscitated from sudden cardiac arrest and who attended in the follow-up arrhythmia clinic at Ain Shams University. This retrospective study included 246 patients who died or were resuscitated from sudden cardiac death, and these data were extracted from 5,000 records of the arrhythmia patients following up in the arrhythmia clinic at Ain Shams University hospitals from the period of January 2010 to January 2020. And the study included patients from 2 to 40 years of age. We excluded patients above 40 years. We excluded patients who died from any other causes like accidents, for example. And the records of the specialized arrhythmia clinic were reviewed to collect the families of sudden cardiac death. The families were contacted by phone or were invited to attend in the clinic, and all the first-degree relatives participated also in the study. We took detailed personal history, detailed medical history. We took history from the victim or from the survivor about the circumstances of the death, the symptoms preceding the event, the description of the death event, whether it was witnessed or not. And any past medical history was noted, and detailed family history was taken for previous or similar cases in the family. If there is history of sudden cardiac death, any syncope, any arrhythmias, any device implantation, any EP procedure done. And all the investigations that were done for the patients, including echocardiography, if the patient had an MRI or CT, or coronary or Holter or stress ECG, all the labs were revised. Regarding the results, the mean age was 26.5 years. We had more males. We had 140 males. The body mass index, the mean body mass index was 24.1. We had variant socioeconomic status. Maybe the moderate socioeconomic status was more in 170 patients. We had more patients living in urban areas. We had variant risk factors like hypertension, diabetes, and smoking or addiction. But what was significant for us, that the presence of family history of sudden cardiac death was found in 202 patients, which means 82% of all the patients who had sudden cardiac death in our population. Regarding the circumstances of the event, 151 patients had repeated previous syncopal attacks, and sudden cardiac arrest or death occurred during practicing exercise occurred in 38 patients. 2 patients from them had the event during exercise ECG, and 36 patients had the event during participating in sports. 2 patients developed sudden cardiac death during sleep, and 84 patients during normal regular daily activity, and 122 patients developed the event at home without any exercise. Regarding the etiology of sudden cardiac death, the most common cause of sudden cardiac death was hypertrophic cardiomyopathy. It was represented by 50 patients from our study population with a percentage of 20.3%, followed by dilated cardiomyopathy in 47 patients. Congenital long QT syndrome was 11.4%, congenital heart block 8.5%, Brugada syndrome, then Wolff-Parkinson-White syndrome, RV dysplasia was 5% in our population. The implantable devices in our study population, we had 90 patients who had implantable devices. We had 58 patients implanting and had an ICD for prevention, either primary or secondary prevention. Most of them were hypertrophic cardiomyopathy or dilated cardiomyopathy, some cases of primary VF, idiopathic VT, RV dysplasia, long QT syndrome, and Brugada syndrome. We had 20 patients having a CRTD, and 4 patients having CRTP, and 8 patients having a permanent pacemaker in the form of dual chamber pacemaker for complete heart block. Invasive electrophysiological study was done in 18 patients in our study. 1 patient had VT ablation, which was successful, while another 3 patients, the VT was non-induced during the EP procedure. 11 patients had Wolff-Parkinson-White syndrome. They were all successfully ablated. 2 right anteroseptal accessory pathways, 3 post-receptal, 4 left lateral, and 2 concealed and anteroseptal accessory pathway. 1 patient had the parahesian accessory pathway, which was not ablated. The decision of the operator was not to ablate the accessory pathway. We had 2 patients with PVCs, 1 from the RVOT, and it was ablated, and in another patient with an LVOT PVCs, and it was ablated. Then we divided the study population according to the age. Younger age between 2 and 18 years, which included 72 patients, and an older age group above the 18 years, which included 147 patients. And of course, the demographic data, the body mass index was higher in the older age group. There was more patient in socioeconomic status. And we found that regarding the age, we found that we had more cases of hypertrophic cardiomyopathy in the older age group. We only had 6 patients in the younger age group with a percentage of 8.4, and 44 patients in the older age group with a percentage of 25.3, which was significantly, statistically significant. Also, the dilated cardiomyopathy was statistically significant, having 5 patients only in the younger age group, and 42 patients out of 147 in the older group, which was also significant. All other causes of sudden cardiac death in our study did not differ between the younger age group and the older age group. We once again divided the study population into 2 groups according to the presence of family history. In patients who had positive family history, which are 202 patients, and we had another group with negative family history who did not have any family history of sudden cardiac death, which were 44 patients. From the 202 patients who had positive family history, we had 103 patients having 1 member developing sudden cardiac death before. We had 51 patients having 2 members of the families. We had 33 patients who had 3 members of the family. Up to that, we had 2 patients having 7 members of the family who had a previous sudden cardiac death in 2 patients. Regarding the comparison or the causes of sudden cardiac death according to the family history, we found also that the hypertrophic cardiomyopathy was significantly different between the patients who had positive family history in comparison to the patients who did not have who did not have family history, 46 patients out of the 202 with a significant p-value. We had also another finding that the cardiac death due to Brugada syndrome was more in patients who did not have a family history, 15.9% versus 5.4% in the patients with positive family history. So in conclusion, we found that family history, of course, was the most common risk factor of sudden cardiac death, and accordingly, it could be a reliable predictor of high-risk patients for sudden cardiac death in these young patients. The most common cause that we found was hypertrophic cardiomyopathy followed by dilated cardiomyopathy, and this also applies to the age group between 18 and 40 years. Hypertrophic cardiomyopathy was found to be more common in patients with positive family history of sudden cardiac death, and cardiac assessment of family members of patients who experience sudden cardiac death is very important, as many causes of sudden cardiac death could be familiar in origin, and screening of these families are strongly encouraged, with special emphasis on the features that suggest a cardiac or underlying cardiac disease like cardiomyopathies or inherited primary electrical disorders. Thank you very much.
Thank you, Dr. Ahmed, for a wonderful talk. موضوع